Okay, let's make sure this sounds right. Let's take a look. Let's take a look. Let's take a look on YouTube and see how this sounds. Let's take a look, shall we? How do we sound? I think we sound okay. All right, that's good. Let's make sure we can share this. Let's make sure we can share this. Let's take a look here. Okay, I'm going to go here. I'm going to go here. I'm going to go here. Let's take a look. We're going to share it on Twitter, and then we're going to get going. And we're going to see what happens. Okay. Here we go. I think we're going to post it. I'm going to say everything's good to go. I think everything's good to go. And if that is the case and everything is good to go, then we're just gonna run it and see what happens. You know what I mean? We're just gonna see what happens here today. All right, it's 3:00 Pacific Standard Time. Let's get this show on the road. So my name is Dr. Patrick Lockwood, and for the purpose of this podcast, I'm just Patrick, and this is UnShrink Me. So welcome everyone. This is a weekly podcast on mental health. For those of you who don't know, UnShrink Me is about everything related to mental health. And so this ranges from everything in the scientific side of things, what does the research on clinical psychology and psychiatry say, to the pop psychology side of things. What do famous influencers say about mental health on Instagram and Twitter and things like that? Famous YouTubers, etc. And so it covers everything. And I have a background as both a clinical psychologist and as a professor and as a therapist and as a treatment center operator and as a consultant. So I have so many different things. A clinical supervisor, I just have so many different lenses through which I see topics related to mental health. And so I try to bring all of those to bear on these various topics that we discuss every week on this podcast. Last week's podcast was admittedly a little deeper and a little heavier because of the current events in the United States, but this week should be a little different in its tone, a little more positive, a little more focused on solutions compared to last week to some degree. So hopefully this week is a little peppier, a little cheerier. I always want to say, please like, share, and subscribe to my YouTube channel if you can. It would be great if I could get my subscriber count up because I'm trying to, get monetized and all these fun things. But also, I'm trying to make sure that essentially anyone who seeks out mental health services gets the best possible information and the best possible chance to get what they need from their mental health providers. So the real purpose of this podcast is genuinely to take care of the consumers of therapy and the consumers of psychiatry, because it's actually the case that, unfortunately, many professionals, or people who call themselves professionals, aren't really selling the correct services, or they're overselling things or underselling things. And so the whole purpose of this podcast is not safety necessarily. I'm not trying to protect necessarily consumers, but I'm trying to educate people. One of my big passions in life is to be an educator, and I am lucky to be able to do that at least part-time. And so I think if people have the right access to the right information, they can make better decisions about how they seek out mental health services and how they understand what their clinician is trying to do with them in therapy or whatever it is. And so the spirit of this podcast is, can you get a perspective that's helpful so you can get the most out of your services that you're seeking out right now? So that's the whole point of the UnShrink Me podcast. I am open to any and all conversations. So if you're here and you're watching, please feel free to join the chat, chime in, say what you want to say. All are welcome. I don't care what your politics are. I don't care what your gender is. I don't care where you come from in the world. I don't care what your religious beliefs are. I don't care what you look like, and I don't care what you sound like. You are welcome here. All are welcome. All I ask is that you either try to be funny or you try to be productive. And so long as you do one of those two things, welcome to the chat, and it's going to be a good time. As always, this podcast is not NOT, sponsored by Celsius, but I do love this stuff. So I'm going to be taking a couple of different drinks from a couple of different things today. Good shit. So let's look at the topics for today. Today we're going to talk about neutrality and empathy. We're going to talk about care. We are going to talk about anti-psychiatry nonsense, as there always is some. And we're going to talk about attitudes. So let's start with this post from Dr. James Davies, who I've talked about before on the podcast. Let me just start by reposting it so everyone can see it. He put out a tweet on 9/1, so September 1st. Okay, here we go. So here's what Dr. Davies said on September 1st. He said, and I quote, "The psych status quo would much rather you believed in the authority of experts than in the authority of science and evidence." Okay. So this is another one of those polemical tweets, right? He is attempting to get people to react, and here I am reacting. So good job, Dr. Davies. Here's what I will say about this, and this is something, I was at a conference this week and I talked about this too. There's a world of difference between someone who claims or proclaims expertise, or someone who believes that they're smart, or that someone believes they're right. So I think those are three different flavors of people. Sometimes they overlap, sometimes they're the same person, but often there are different people out there in the profession of psychiatry, clinical psychology, etc., who believe one or all three of those things. So for instance, let me just speak to something real quick about the concept of expertise. So expertise is one of those very loaded words, right? And a lot of people in the profession will claim some degree of expertise, and maybe that's based upon their training and their education, just the number of years they've been successful in the profession, or maybe it's because they just know a lot of stuff. And I think there's absolutely nothing wrong with knowing a lot of stuff. There's also absolutely nothing wrong with just having been around a long time and knowing a lot just based upon that. I think being smart and knowing a lot of stuff is not the same thing than like being an expert, especially when it comes to clinical psychology, psychiatry, and the like, because like there's a technical level of detail that you can totally engage with that might be helpful to patients. But in the mental health world, your book smarts, like all the stuff on my bookshelf back there, there's a really good chance that just me knowing everything in those books back there is not going to be particularly helpful. In fact, I would argue 9 times out of 10 that it's not super helpful to be super book smart. And the reason I would say that for at least new clinicians in particular is there's two problems. And I'll get back to what he said about expertise in particular. But there's two particular problems about this expertise conversation when it comes to knowledge, right? So he said, Dr. Davies said, science and evidence, right? So when we talk about science and evidence, we're talking about generally like peer-reviewed literature. We're talking about things that you should be able to know with certainty because they were published in peer-reviewed journals. Now, the problem with that is, unfortunately, there's a lot of people who publish in peer-reviewed journals who are just straight up hacks. They just have a mistaken belief about things. They like old school myths about things, right? Like I was talking with some of my colleagues about this last week, where they believed, for instance, that, excuse me, I'm fighting off my cat right now who's jumped on my desk. I love you to death, buddy, but, this is not the time. So, come on, bud. Sorry, I am being invaded by Max. Here, let's get this out of the way. So Max is here. He's huge. He's this big guy. He's this huge guy. And I love him to death. I really do. I love you to death. And you're currently, I know you're a little needy and you want some attention right now, but now is not the time. My friend, get out of here. All right. I think we handled that. For those of you who are just watching, I'm not choking my cat. I was just rubbing his chin. He's funny. Anyways, so I want to talk about science and evidence because that's what Dr. Davies referenced. And a lot of people who are very smart, they're book smart, they have science and evidence on their side. But the problem is much of what is published in clinical psychology and psychiatry journals is on the edge of being garbage, if not garbage, because unfortunately, many of our samples are underpowered. There's very few participants. Many of our constructs that we use aren't very solid or reliable, like many constructs in psychology, like trauma, are very nebulous. So how are you operationally defining trauma, for instance? And then second question to that is what measures are you using, and are those really reliable and valid measures or not, right? So psychiatry and psychology struggle from what we call, in a scientific sense, a crisis of construct validity. Many of the things that we believe are true, because there's dozens and dozens and hundreds of peer-reviewed papers, are kind of built on a smokescreen, right? Or this this pile of garbage that sounds fancy and correct, but it's actually not. So not to disparage clinical psychology more generally, just to say that people cling very strongly to things that are quasi-true, not actually genuinely true across time and space. Because construct validity is lacking in many things in clinical psychology and psychiatry. So someone who's super book smart, who understands everything I just said, might be very defensive because they have their sacred beliefs around, what trauma is or is not, what, I talked about this in class last week, what are microaggressions and why are they not valid and why are they valid, right? In what way scientifically are they valid and what way scientifically are they not? And so the problem with many of these topics is that people are not responding to a fully nuanced 360-degree, 30,000 foot down looking view of what things are scientifically in terms of construct validity and things like that. People are looking at what they emotionally believe is true. Even PhDs and MDs and all these people, they have sacred beliefs that push them to want to know and reify these concepts that matter to them. So a lot of people think they're experts just because they've been around and they've survived in the field for a long time. That doesn't necessarily make you an expert, because you can be mediocre for a very long time and have an okay reputation and people still refer patients to you. That doesn't mean you're actually good at your job or you see things correctly. But also, just because you have a lot of knowledge, like I do, for instance, knowing a bunch of shit doesn't mean people want to work with you, because you can be a super smart person, but you can be a miserable piece of shit. And if you're a miserable piece of shit, even though you know everything and you see things perfectly or whatever it is, patients aren't going to want to work with you. People aren't going to want to refer patients to you because they don't know how to deal with you, because you don't seem trustworthy, because your personality smells funny, because you're like me, you're too disagreeable, or you're a little too off the cuff, or whatever it is. And fair enough. Sometimes there's a good reason for people to be suspicious of you. Now, that being said, I'm not trying to say there's no objective way of knowing if someone is trustworthy and reliable. I'm just saying that the people, the professionals you can trust in mental health, probably shouldn't be appealing to their authority in the sense that they're the smartest or the most seasoned. You probably should be trying to see if they are face valid, number one, if they check out based upon how they talk. But number two, are they able to understand their job with you correctly? And like if you're seeking out therapy or psychiatry, what really is the job of a therapist, a clinical psychologist, an MFT, an LPCC, whatever it is? Like what exactly is your job as a therapist? And if you're a psychiatrist or psychiatric nurse practitioner, what is your job in that particular role? Because depending upon the clinical problem, the presenting problem, and the various types of issues you have that are like concomitant to that, you're going to have a different job. Sometimes, like for me, in my clinical life, not my professor life or my consultant life, but in my clinical life, sometimes I'm just kind of like a crisis manager or a hostage negotiator for very, very ill people, right? Which is different than doing long-term psychodynamic therapy to resolve some childhood trauma stuff, right? Like those things I'm not particularly good at, nor am I interested in. So when you talk to a therapist, you really want to know what they're good at, what they're interested in, what they're capable of, and how they understand their job. Because some people understand their job is to heal everything about you, which is just bullshit. Because it's impossible. That's not our job. We're not capable of that. We're not magicians or something. Also, some people believe that they have such a limited role with you that they can minimally help you, which is also probably not true. So be careful of the people at the extremes is kind of one way of summarizing this. Because the people at the extremes often are just acting out their biases and stuff like that. People who sound reasonable when you interview them or talk to them on the phone, people are like, yeah, well, I'm trained in this kind of trauma therapy. I'm trained in this kind of cognitive therapy, whatever it is. And I typically help people over the span of 6 months or a year or whatever, right? Like when people sound generally reasonable, you can expect that they generally are trying to be reasonable. Some people are faking it because they don't want to be caught or whatever for their personality disorder. But like most clinicians are just like average people. The average clinician is an average person. I wouldn't expect them to be especially smart or insightful or capable. They're average, which means they can help you in an average way. That doesn't mean they're going to hurt you. They might hurt you in an average way, but for the most part, they will help you in an average way. So it's very important, I believe, to not buy into expertise based upon book knowledge or just years of experience, or to discredit book knowledge or experience, because there's usually an intersection of both book knowledge and experience with your capacity to fluidly work with the things you know and the experiences you've had. So you want to see that someone's, to be technical about it, epistemically humble. They're capable of taking a look at themselves and going, I might be right, I might be wrong, for these various reasons. I think if you were to ask one question of a potential therapist or psychiatrist is, tell me a time when you figured out that you were wrong and how did you correct your course with the patient? That's a great question, because either they're going to say some bullshit story, or they're going to tell you a real story about a time that they totally missed something or forgot something or made a mistake, and they'll tell you how they tried to rectify it. They might have even failed to rectify it, because that happens sometimes. And that's what I want to hear from people. I want to hear how you figured out how to do things better. If you're a good clinician, a good mental health professional of whatever degree level and whatever kind of training, you're going to be honest about the fact that you have limitations and that you have some strengths or gifts in some way, but there's still limitations, right? That is where people are truly honest, when they can get to both of those statements. So, dear Dr. Davies, the psych status quo would much rather you believe in the authority of experts than in the authority of science and evidence. I don't believe there's any authoritative position. I don't believe that experts are more authoritative than the science and the evidence, because the evidence is corruptible. The research that's done is at minimum imperfect and at worst corrupt in many ways. Corrupt by big pharma, corrupt by many of the granting organizations, and just a terrible construct validity of some of these constructs that people believe in. Like there are still people in educational psychology who believe in like learning styles, and that's been dead for like, I don't know, 15 years, 20 years. So thank you, Dr. Davies, for getting this thing kicked off as always. Moving right along. Let's talk about Jonathan Shedler. So Jonathan Shedler is a therapist on Twitter, and he is often very talkative, and he put out a really cool post that I think would be helpful for everyone to understand. Might help you make a better choice with an upcoming clinical appointment if you have one, etc., or to refer people out, or just to understand people better. So let me repost it real quick, and then we'll talk about it. Okay. So Jonathan said, and by the way, his handle is at JONATHANSHEDLER. And here's the post that he put out on September 3rd. And I quote, "When people hold different views, it may be a difference in perspective, but it may also be a difference in development," in quotes. "One thing that indicates higher and lower levels of development versus mere difference of opinion is asymmetry." He gives an example. A 10-year-old understands the thought process of a 5-year-old and understands where they go wrong, but the 5-year-old doesn't understand the thought process of a 10-year-old. That's asymmetry. Likewise, an expert can understand how a non-expert thinks and comes to a mistaken conclusion, but the non-expert doesn't understand how the expert thinks. Not everything is just difference in perspective. There are real differences in development, for instance, knowledge, understanding, ability, thought, and skill. Asymmetry is one indicator, symptom I might say, that a developmental trajectory exists. Higher levels recognize lower developmental levels. Also, they typically don't judge them. This is my comment. Lower levels cannot recognize higher levels. Research shows this, like the Dunning-Kruger effect. He says one implication is that at low levels of development, there may be no recognition that expertise exists. This explains quite a lot. So I want to take this in context of what I just said. There certainly is expertise, right? That's what I was saying. But when people hold a special reverence for expertise without acknowledging the limitations of expertise, or a special reverence for serious amounts of knowledge, even though you might not be able to apply that knowledge, etc. Like Jonathan's perspective makes perfect sense in the context of what Dr. Davies was just talking about. People who are underdeveloped, and this is not just with regard to clinical psychology and therapy training. This is with regard to any facet of life. Some people are very limited in their insight, and they don't know it. They have a bias, a defense mechanism like denial or repression or whatever it is, that keeps them from being able to see the ways in which they ignore perspectives that are more complicated, that are probably correct, that look at the nuances of things that they can't handle. A lot of people cannot emotionally tolerate conflict internally or even externally. So for instance, people who are temperamentally very agreeable in their personality, even if they're very intellectually smart, like high IQ, even when you're very smart, you still can't handle a lot of conflict because your personality is built a certain type of way. If you score very high, 80th percentile or greater on trait agreeableness, you will avoid and have a very strong negative reaction to conflict. That's just how you're built. And so you might have brilliance in some way, but you might be very limited in your capacity to tolerate internal ambivalence and external conflict. And that's okay. You're just built differently, but that doesn't mean that you can handle and speak intelligently about conflict if you're built that way, if that makes sense. So you might be developmentally delayed with regard to the capacity to handle conflict if you are built the wrong kind of way, for instance, or if you haven't had the right kind of mentorship and development. Because like a good clinical supervisor, for instance, in Therapyland, again, Therapyland being the world's worst theme park, a good supervisor in Therapyland will help you develop awareness of these blind spots, these weaknesses, your differences, if they're not weaknesses, just your differences, so that you can counteract them, right? So if you are temperamentally very agreeable, you're not going to have a lot of expertise in managing conflict until you work through that and get awareness of it and get a handle on it. Likewise, if you're temperamentally very disagreeable, that will also make you very narrow-minded around conflict, which will affect the way you deal with people who are built differently than you. And so good supervision is necessary to develop competence and get rid of the, let's call it the asymmetry that Jonathan Shedler is talking about here, if that makes sense. Okay, sorry. It just looks like it froze real quick. So I just wanted to double down on something Jonathan was saying is like, you can have a different perspective if you are just built differently in terms of your interests, your culture, your personality. But you can also have a different perspective if you're not super insightful or emotionally underdeveloped about a particular topic or category. It does happen. And so this is especially important for all of you who like really get worked up over social media and news and late night TV shows and things like that. Like, there are a lot of people who hold opinions that you can't tolerate. And that might be because those people are underdeveloped. It might be because you're underdeveloped, right? Like, if you pick any political topic of any kind, there are a lot of people who just have strong reactions, and those strong reactions are fine. There's nothing pathological about them necessarily. But your inability to tolerate your strong reactions and other people's strong reactions might be about your level of development. And so it's very important to be clear about your level of development. So if you're, for instance, if you're out there and you're listening and you're a therapist or a future therapist, and you are looking to improve your work and get better at helping people, one thing you should try to get clear on is your level of development, your level of differentiation, not just your intellect, but your level of emotional awareness, awareness of your personality, of your interpersonal strengths, your interpersonal deficits. Because once you're aware of any asymmetries and any discrepancies like Jonathan talked about, you will then be able to find a new way to work with people and actually help them more. One of the big differences in my clinical experience and my supervisor experience between a naive therapist and like a developing therapist and like a fully fledged therapist is they have differing levels of self-awareness and the speed with which they act on things and the consistency with which they act on self-awareness that affects the way they do their job as a clinician. Very, very green clinicians, very naive clinicians, uninsightful people will be aware, minimally or not at all, of a discrepancy in their emotional development or their childhood stuff or their dad stuff or their mom stuff or whatever it is, and not be able to act on it because they're not very aware of it. And very naive people who, by the way, there's a lot of naive people that come into therapy. There's people who like have their own damage and don't want to grow up. They just want to fix other people because they're trying to fix themselves. But like then there's like those moderately aware people who will see things and then start to act more quickly on what they see in themselves, right? And that's where probably the vast majority of therapists are. The vast majority of therapists are, again, average or mediocre. And so they will be inconsistent in their awareness and inconsistent in acting on things. But usually when they see something, they will act on it and do something about it. They'll see a countertransference problem. They'll see a difference in their developmental level, their inability to tolerate sadness or their inability to tolerate anxiety or helplessness or anger or whatever it is, right? And then they'll do something about it inconsistently. They'll like be aware of it for a while and then it'll like be hidden away again by suppression or repression. And then they'll try to move on. So like, if you want to develop that kind of more expert level way of functioning as a mental health professional, your job is to be as aware as possible about your countertransference, your bias, your cultural misgivings, your developmental differences, and do something about them as frequently as possible, as quickly as they show up. So like an expert will be in the moment, noticing something and doing something about it. And that's hard to do because it requires being super self-aware, but people are capable, I promise. So thank you, Jonathan, as always. All right. Let's talk about Dr. Roger McFillin. All right. Roger, I think, at Dr. McFillin, said on 9/7, I'm just going to repost it real quick. Okay. He said on September 7th, this is a direct quote from Dr. McFillin. Who the fuck would need to go to a doctor and fill out a screening measure to tell them they are depressed? In quotes. We have collectively lost our minds, literally. So, dear Dr. McFillin, I believe that there is some bias you have where you believe that, there are no people whatsoever who need meds and who need to be screened for depression. And it's funny because I think there was a Joe Rogan guest maybe a week ago or something. He was talking about the PHQ-9. Oh, it was that guy from Ways to Well was on the Joe Rogan podcast. And yes, the PHQ-9 does not actually tell you if someone's depressed for sure. It's not designed for that purpose. So Dr. McFillin is saying, I can't believe people go get these cheap, simple screeners and then get psych meds because of them. So the stereotype, which is probably true, unfortunately, in the United States is people that are struggling with low mood, I'm sad, I'm angry, I'm hopeless, I'm irritable, whatever, will go to their GP for their annual checkup. And the doctor will give them a PHQ-9 or something. And the PHQ-9 score, which is a depression screener, will be high. And they're like, oh, maybe you should be screened for depression. Maybe you should try an antidepressant. And it's kind of like that simple to get antidepressants. Unfortunately, in many cases it is. And that's bullshit because that is not how you do a mental health screening. So I agree with Dr. McFillin that yes, it's the case that people who do lazy clinical work should be ashamed of their behavior. General practice doctors, psychiatrists, psychologists, LMFTs, LPCCs, whatever. If you're doing lazy clinical work, you should feel bad about your behavior. You should feel guilty because you're not helping people and you're not doing your job. People are paying you money to help them. That being said, there are also plenty of competent and thoughtful psychiatrists who try to look at people in all of their layers, all of their complexity, socially, psychologically, social determinants of health, neurobiological differences, family of origin issues, systemic issues, all these things. There are plenty of good professionals. I live here in LA. I see plenty of them every week. So when people make posts on social media talking about how psychiatry is corrupt or mental health is corrupt because people just get meds for no reason, it's like, yes, that happens. And it happens way too frequently. It absolutely happens way too frequently. People are over-medicated and underhelped. Lazy practitioners, and they're probably lazy for good reason. They're lazy because in order to make a living, they have to see 50 people or whatever a day, which is terrible. Or whatever, right? Like, there are usually good, valid, and cowardly reasons why different types of practitioners choose to be mediocre. Because I'm going to say that again, many people in the profession choose to be mediocre. They choose to throw up their hands and say, well, the system is broken. Well, the system is corrupt. Well, this is what I was told I was supposed to do, and that is what I will do. And that is mediocre thinking. That is like normie, mediocre thinking, and it's not rare, it's common. The reason for that is complicated because it is hard to be an outsider. It is hard to say, I'm going to be critical of the profession like I do and other people I know do. It is hard to say, I want to go above and beyond, even if it's not going to pay me good right now, but it might pay me good in a couple of years. People have real financial needs. People are worried about their jobs, right? And that's all okay. And I don't judge that, right? That's all normal. And it's unfortunately, it's the world we live in, And so it's okay that people are like that. We have to come to terms with the fact that society is built this way. Managed care is built this way. It's not weird. So there's all sorts of systemic reasons, all sorts of personal reasons why medical professionals, psychiatric professionals, mental health professionals of all kinds and all backgrounds just do what the status quo is. Because it's safe to be in the middle of the herd. It's safe to do what everyone else thinks you should do. It's safe to talk about what everyone else talks about. And I think for Dr. McFillin and Dr. Davies in particular, it's safe to just be a complaining skeptic without trying to be nuanced. And here's what I will tell everyone, that there are some people who absolutely need psych meds. I would be shocked if there were 0 people on the planet who needed psych meds. That would be completely surprising to me. I have worked with so many people with severe schizophrenia, severe bipolar, that if they didn't have meds, I don't think they would just magically remit on their own. That would be surprising to me. So, do some people get antidepressants when they don't need them? Yes. Some people get antidepressants when they don't need them. That's true. Okay? That's true. And even though medications are overprescribed, they are still necessary. Because for some people, they actually genuinely help. And that's not a controversial statement. And for some people whose depression is so severe that they can barely manage to even get to like a therapy appointment, they need extra support. Now, is it chemical support? Is it therapeutic support? Is it family support? Whatever it is. Some people need disability, right? Some people have such severe mental illnesses that they literally cannot function in today's society. But is that most people? No. In fact, the vast majority of people with a mental health diagnosis will not actually need therapy in order for their symptoms to remit. Maybe it would be helpful if they had therapy, but they wouldn't need it necessarily. Because most people's mental health conditions are mild or moderate, which means that with lifestyle change and support and insight and coping skills and things like that, they will get better. But that doesn't necessarily mean it has to be therapy kind of support for them to get better. So that's that. Okay. I want to talk about another Jonathan Shedler post. Okay. By the way, in this mug is Celsius and something else. So let's talk about Jonathan's post here. Yeah, this is going to be a good one because I think it's really important for everyone to hear, whether you're a patient, a family member of a patient, or a therapist, or a professor, or whatever. That's good stuff. So let me just post it and we'll get going. Okay. So on, I think it was August 14th, so a couple months ago, Jonathan said this, or a month ago, excuse me. Jonathan said, once you dispense with the principle of neutrality, which means absolute, inviolable respect for the patient's agency and self-determination, anything goes. Then there's no definition about what it means to be a therapist also. So let me just restate his definition of therapeutic neutrality. So as a therapist, being neutral. The principle of neutrality is absolute, means no exceptions. Inviolable, which means you can't violate it. Absolute, inviolable respect for the patient's agency. So respect for two things. The respect never changes for these two things. Agency and self-determination. So agency is about skill, your capacity to do things. You respect that the patient is capable of doing things. Number one. Number two, you respect that the patient has a right to choose what to do, self-determination. Okay, so I want to say that again. In Jonathan's perspective, neutrality in therapy means you have unchanging, unwavering respect for, which means it's sacred. It is sacred that patients are both capable and have full choice, full free choice to do whatever they want. Okay, so what's interesting about this concept of neutrality, especially in the light of like politics and the world being on fire and all this stuff that's been happening for the last few weeks, let me say this very clearly. No human being is neutral. No human being is a centrist. No human being is unbiased. No human being is so Buddhist, so mindful, so perfectly full of equanimity and shit that they are neutral. I am not neutral. You are not neutral. None of us are so healed. None of us are so zen. None of us are so perfect that we can see things with absolute clarity, perfect clarity, and perfect non-judgmental neutrality. It is impossible to be that person. So if you believe you are morally pure and morally neutral, you're full of it. You are not morally pure. You are not morally neutral. None of us are. Not a one of us. Not a one of us is morally pure or morally neutral. None of us are. So what I want you to think about is the fact that although therapeutic neutrality is an ideal all mental health professionals should be shooting for in the way that Jonathan described it, you as a person, as an individual who is a mental health professional, are incapable of being neutral. So I hope that difference makes sense to everyone. So what clinicians are doing is not themselves being perfectly neutral. We are not capable of that because therapists are human beings, which is awesome. Thank God we're not robots. Like AI is never going to make a good therapist because people want people. People want relationships. But what good therapists do, what therapists who love and respect their patients do, is they practice. It's a practice, which means you have to put work and effort into it. Good therapists practice, put work and effort into being therapeutically neutral. And again, the way that Jonathan described therapeutic neutrality is unwavering respect for, reverence for, I would go so far as saying, the patient's self-agency. They are capable. And number two, reverence for self-determination, which is the patient's freedom to choose to do things. Okay? So ultimate reverence for self-agency and ultimate inviolable reverence for self-determination. You, the patient, can choose to do things. Here's why this is difficult for every clinician on the planet, whether you're super smart, super not smart, super healthy, super not healthy, super young, super old, white, black, gay, Hispanic, trans, Uzbekistani, whatever you are equally struggling with this practice, because it is a practice. It's something you have to effortfully put energy into and pay attention to and do better at over time. This is what we all have to be doing to be better clinicians and mental health professionals. We have to put effort into paying attention to the ways in which we as professionals violate the patient's capacity for self-determination and agency. Where do I, as the professional, treat the patient? How do I act with the patient that limits their autonomy or limits their self-agency? How do I act with them that sends the message, you are incapable? If I tell you what to do, that's me telling you you're not capable. If I tell you you're wrong, then I'm limiting your self-determination. So I hope everyone understands the difference between you being a regular person pretending you're neutral and objective and wise and shit, which no one is, which is different than practicing the attitude, like practicing looking through the lenses of self-agency and self-determination. If I'm looking at the patient with ultimate 100% respect for their self-agency, that they can do things, they are capable, number one. Number two, it's their choice, no matter what I think and feel. And I think if every clinician could just get better at that and getting aware, becoming more and more aware of the ways in which we as professionals, either intentionally because we have a bias or unintentionally because we have countertransference that we're not aware of. Because those are the two most common ways where therapists violate patient neutrality and respect for patients. The two most common ways where mental health professionals of all backgrounds, all ages, all genders, all degree levels violate patients' rights and respect for patients is by either having a bias that they haven't come to terms with that violates self-agency or self-determination for the patient, or they have countertransference that they can't see. Right? So let me give two concrete examples of both so you all know what I'm talking about. So here's what's happening when you have a bias that gets in the way of patient autonomy and patient agency. This happens all the time with politics nowadays, right? So a couple of weeks ago, I went pretty hard at a person named Soad. And Soad is this person on Twitter who I think is a good person. I don't think she's immoral or evil or whatever it is. But she specifically started a conservative therapist group, right? And a lot of my criticism, like 2 or 3 weeks ago, whenever this was, maybe it was 4 weeks ago, I don't even know at this time. A lot of my criticism was when we create an environment that's specifically a quote unquote safe space, because those are the words she used. She created a safe space for conservatives. And I detest politics in every way, shape, and form. And that's a bias I have to be careful of, because if I don't pay attention to my bias that I am disgusted by politics, that will affect patient autonomy and agency, right? So likewise, her bias in favor of protecting conservative patients is likely equally problematic as my overall disdain and disgust for politics, which is no different than the bias and problematic nature of being overly left-wing and woke and shit. Like, all three of those perspectives that I just outlined are toxic for patient agency and patient trust. Because when we have a bias, right, like a political bias, like I do and a lot of people do. So my bias is it's all disgusting and I can't believe you care about it. Other people's bias is like, I can't believe you're conservative and MAGA, what's wrong with you? Other people's bias is, I can't believe you're left and woke, what's wrong with you, right? So all three of those biases I just described are equally problematic for patients, because once you have an explicit bias that you're aware of, it's your job to do something to mitigate it, ethically speaking, number one, so it doesn't interfere with your ability to be therapeutically neutral, as Jonathan described. So I'll just make it about myself, not even about SOAD or anything else. So if I think politics is disgusting, then the number one thing I have to do in order to be an ethical therapist or consultant or professor or whatever it is I have to make sure that nothing about my belief system, my emotional reactions of disgust and disdain for politics interferes with my ability to do my job and tell the truth about clinical matters, right? So if Jonathan's definition is correct of therapeutic neutrality, which is ultimate respect for the patient's self-agency and ultimate respect for the patient's self-determination. So the patient's sense of I'm capable and the patient's sense of I have choice. If I have a political bias and my patient's coming to me talking about politics, then if I talk to them in such a way that discourages, because I'm disgusted by politics personally, and if I talk to them in such a way that discourages them away from what matters to them, then that is me interfering with self-determination objectively, which means I'm violating therapeutic neutrality, if that makes sense to everyone. And that's not okay. Like, it doesn't matter, even if I'm technically correct at being disgusted at everyone and everything, that doesn't mean that it's okay to walk into my job as a clinician, as a professor, as a consultant and go, that's disgusting. Why are you talking about it with your clients? That's not okay. That can be my personal opinion. I can have that opinion with my friends. I can talk about it publicly like I am here, but that doesn't mean that I should be bringing that into the therapy room or into my job. I should be asking curious questions of patients when they have political concerns. I should be open-minded as to why they're struggling in the way that they're struggling. I should be interested in what matters to them about these political things. I'm allowed to have my bias. I'm allowed to have my opinion. I'm allowed to hold to these things. I'm allowed to be delusional about these things if I want to as a person. But what I'm not allowed to do is to walk into my professional role and pretend like I'm just some Zen Buddhist. Clearly I'm not, obviously. But I'm not allowed to pretend like I myself am neutral. And I will be this wise sage who's walking you through things. I'm not allowed to do that because what's going to unintentionally happen, or even intentionally, maybe unconsciously intentionally, I'll walk in there and try and corrupt people. I'll walk in there and try to tell them what I think they should hear. I'll walk in there and try to convince them away from their belief systems, which is me corrupting self-determination, which is not therapeutic neutrality. And that happens in clinical psychology all the time now with regard to politics. And it's disgusting, in my opinion. But again, that's my opinion. Other people are like, no, I'm fighting the moral fight. Like, feel free to fight. Good luck with that. But for me, I have to be aware of that bias I have, because that bias will eliminate, if I'm super strong about it and explicit about it, it will eliminate self-determination. I should be curious. When you love someone, when you care about someone, you're curious. When you hate someone, when you loathe someone, when you're apathetic towards someone, you do whatever you want because it feels good to you. So therapeutic neutrality, in Jonathan's sense, involves ultimate respect for self-agency and self-determination. You are capable and you have full free choice to do whatever you want to do while you're with me as a patient. I hope you all understand that, because that's super important in my opinion. In fact, I believe it's the most important thing that a good clinician can do. But it's just extremely hard to do, especially nowadays, because nowadays everyone has 24/7 access to everyone's thoughts and feelings. And so we're not allowed to even have a private life, or we don't even think of each other as private people. We're just public. And I'll admit that I'm here contributing to that, but like, your mental health professional doesn't have to be your friend. They don't have to be your bestie. They don't have to be your dad or your mom, and they should be none of those things. Mental health professionals should be only one thing. We are paid support for a specific problem. We are not, N-O-T, your friends, your lovers, your family, your dad, your mom, your brother, your ex. I'm not your coach. I'm not your guru. None of us occupy these other roles. It's unethical and frankly immoral because of the privileged, powerful position that we hold, especially emotionally. And so our job is not to be activists, is not to be anti-activists. Our job as professionals is to be one thing and one thing only: flawed but dedicated and ethical people who are interested in doing the right thing. And one way to look at the right thing as a clinician is to look at, how am I engaging in self-determination? How am I helping a patient develop their sense of I have choice? And how am I helping a patient develop their sense of I am capable? So that's self-agency and self-determination. Self-agency, I am capable. Self-determination, I have choice. Good therapists, no matter what your bias, no matter what your countertransference, can sit with anyone even the people that you have the most strong emotional reactions to or countertransference reactions to, can sit with those people that they disagree with or don't like or whatever it is and go, how can I help you have more choice and more self-agency? And that is what's missing today, but it's totally capable. Everyone is totally capable of developing more of that therapeutic neutrality as Jonathan Scheller described it. And the reason I believe this is because I see it every day. I see it in the clinicians I get to mentor, in the staff I get to mentor. I see it as a professor in graduate psychology. I get to see these students grow and see more of their bias and more of their countertransference and how they have a better relationship with it. And then they treat patients with more respect and they get better clinical outcomes. I'm here to tell everyone that it's getting better, and it will get better because there are so many people who are out there who are like-minded, who are interested in doing the work better and being more respectful of patient autonomy despite politics, despite social media, despite the craziness of our times. Yes, if you looked at Twitter or if you lived in Rehabistan or whatever, it looks like life is a dumpster fire. But the truth of the matter is, if you go outside right now in most cities in the U.S., you're not going to get shot. You're not going to get stabbed. You're not going to get killed for your political beliefs. Unfortunately, that happened a couple of weeks ago. But the vast majority of people are just regular people. And the vast majority of people will be understanding. And the vast majority of mental health professionals are smart enough and capable enough with good supervision and good training and good mentorship to teach you to become more capable of treating you with respect for your autonomy, for your agency, for your self-determination. And so if you can find a therapist or an intern or a psychiatrist who can help you develop self-agency and self-determination, that's a person who respects you. That's a mental health professional who's doing their job correctly. If you have a mental health professional who's trying to convince you of something, they don't respect you. If you have a mental health professional who's trying to manipulate you, they don't respect you. Now, sometimes they manipulate you because they're in fear themselves. They're trying to control you because they're afraid or they're underdeveloped themselves, like we talked about earlier. But that's not because you are unworthy, and that's not because you're broken. That's because they don't have a handle on their lack of personal reserve and accountability and maturity themselves. But be hopeful. I hope all of you are optimistic, because most clinicians are capable of treating you with more self-agency and more self-determination. Clinicians are capable, even mediocre clinicians can help you develop self-agency, the sense of I am capable, and the sense that I have choice, because you always have choice. You literally always have choice. Sometimes your choices suck, but you always have choice. And it will always be okay so long as you realize you are capable and you have choice. And that is what I want everyone who's listening and watching to walk away with today, is that you always have choice and you're always capable. And if you can hold on to those two truths, then things will get better. Because at some point, through luck, through circumstance, through time, through therapy, whatever, you will be able to act on that choice and that sense of I am capable and make changes in your life, and things will get better. And that's what good therapy does. No matter what the modality, EMDR, motivational interviewing, ACT, CBT, DBT, whatever, it's all the same. Like, good therapists find the right words, the right skills, the right tricks to help you see how capable you are and how much choice you have in your life, and to have a better relationship with yourself so that you can act on your capability and act on the choices around you in a way that serves your goals, your needs, and your values. So take heart. It's going to get better. I believe it's going to get better because I see it getting better in my local area. And LA is a dumpster fire of a culture, but it's getting better here. So if it's getting better here, it can get better everywhere else. And I see plenty of people who want it to get better, and they're out there doing good work. So have hope. Be optimistic. Okay? So thank you all for coming out and listening. It looks like we didn't really have much chat today, and that's totally okay. But I'm really glad you were here. I'm glad we could talk about self-respect, respect for patients, levels of differentiation, anti-psychiatry nonsense. It's all good. And it's going to get better. And I believe it's going to get better. So please, if you found anything about this interesting, useful, funny, helpful, please like, share, and subscribe. Please help me get the word out so we can spread more encouragement, more honesty, and accountability for mental health professionals so that you can get more of what you need from the service providers that you're seeking out or currently working with. My goal is to create as many useful clips and sound bites and all this stuff that something gets out there and helps people actually get more from their therapist, more from their psychiatrist, more from their coach, their counselor, their case manager, whatever it is. Like, you can get more and it will get better if you get more, for sure. And it's capable. We're all capable. It's always possible. You're never not capable, right? It's just sometimes we don't feel capable, but you are capable. So, thank you all for being here. Thank you for watching, listening, etc. And as always, I like to end this with a joke of some kind. So let's give it a whirl and see how it goes. So I once had this patient, and he was a really interesting character because he's kind of quirky, kind of nerdy, but he had a lot of relationship trauma. He'd had a lot of breakups. So he had some people cheat on him. He had some people lie to him. He wasn't a particularly assertive fellow. He was kind of a passive guy, but he was a nice guy. And he was just having the hardest time. So we kind of were talking about some of the trauma he went through and things like that. And he ended up dating this police officer, which is interesting because, most of the time, I just don't hear about people dating cops. But this guy was dating a cop. And so he was talking about it over the weeks. And this cop was kind of interesting character. Seemed like kind of like a nice person, a tough person, martial artist, police officer. But like they had a good relationship and they were on like their 4th or 5th date. And she said, I think it's time for us to get serious and like, I don't know, something like be official or whatever. And so she's like, I want to be your girlfriend. And he was kind of hesitant. He said, well, let me talk to you at our next date or whatever. So he came back to therapy the next day and he was just telling me about the date and it went well. And she kind of reminds him of his mom in good ways and all this stuff. And he's like, I feel really conflicted, Dr. Lockwood, because, many of her traits are just awesome and I like her and she kind of challenges me and she scares me a little bit, but I like her and she really wants to like move forward and like make it more serious. But I'm kind of on the fence. And I said, it sounds like she's kind of got you under arrest. All right. Have a good week. Have a good weekend. Take good care of yourselves. Please encourage each other because the world needs it more than ever. And I will see you in a week.